Hi, everybody, and welcome to a Preciska GI Cancer-Focused Tumor Board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
It's a 66-year-old man with a history of a stage 3 T2N1 microsatellite stable colon cancer. It was a moderately differentiated tumor of the rectum, underwent neoadjuvant chemotherapy, followed by short course radiation, followed by surgery, now on surveillance. So the question is really about how would you approach a recurrence? Again, the history: asymptomatic patient found to have an elevated CEA when he declined a screening colonoscopy. Kind of a lucky catch, I guess. Medical history: a patient has a history of a TIA, hyperlipidemia, hypertension, and an unknown family history. So the specific details: in February of 2020, patient had a colonoscopy, so I guess ultimately did undergo the colonoscopy after previously declining. Had a mid-rectal tumor, superficial fragments of adenocarcinoma, predominantly moderately differentiated, mismatched repair proficient and microsatellite stable. A month later, underwent preoperative staging imaging, CT chest abdomen, which I will let Dr. Siegel comment on the MR, but the CT showed focal mid-rectal wall thickening up to 2.3 centimeters, compatible with a known tumor. A large superior rectal node, short axis diameter of 13 millimeters, and some sub-centimeter iliac nodes. Don't know if it's internal, external. MRI pelvis, I will show you. Patient also had a endoscopic ultrasound with a T2N0 tumor, and the pre-treatment CEA was 4.4. So here are the available rectal MR images.
So we have here a high-resolution sagittal MR, a high-resolution axial MR, and then the image on the right is a diffusion imaging with a high B value. And if we just focus on the middle image first, it shows us an irregular area of thickening involving the anterior aspect of the mid-rectum. And also on that same image, posteriorly and to the left, we can see that enlarged lymph node. So for MR criteria, we use all lymph nodes greater than 9 millimeters as positive, and lymph nodes between 5 and 9 millimeters are considered positive if they're round, they have a heterogeneous architecture, or they have irregular margins. They have to have 2 out of those 3 criteria. Lymph nodes greater than 9 millimeters are just considered positive. So probably on MR, we would be staging this as at T2N1.
Excellent. And maybe just briefly while we have you, can you comment on the concordance between ultrasound and MR, or whether or not both are needed?
I think oftentimes they are both complementary. And I don't know that ultrasound has as wide of a field of view to look at lymph nodes, and especially as the tumors get higher and closer to the peritoneal reflection, I think MR it provides a much more critical role. So I think they can both be helpful, and oftentimes they'll have overlapping but slightly different areas of where they really are strong. MR is definitely the field of view and the diffusion. And again, for tumors that get up higher, down near the anus and the musculature, I think ultrasound does very well.
Yeah, no, that's super helpful. I know it's a conversation that happens a lot at probably all of our institutions. So the patient had a preoperative PET CT or pretreatment PET CT with the hypermetabolic primary rectal tumor, the pelvic lymph node that was commented on, suspicious for regional metastasis. In June 2020, the patient completed neoadjuvant 5-FU leucovorin oxaliplatin 6 cycles. Patient did have a TIA, it seems. This was followed by a short course of radiation, 5x5 presumably, or 2,500 gray and 5 fractions. And then in August, underwent a laparoscopic proctosigmoidectomy with a coloanal anastomosis and loop ileostomy. Was staged as YPT0, YPN1A, post-op imaging with a decrease in the CEA on serology and no evidence of metastatic disease. And then several months later underwent a closure of the loop ileostomy. So before we get into talking about recurrence, I think rectal cancer is a big topic with an evolving field. And I know several of you in your institutions have been involved in the efforts to sort of move towards total neoadjuvant therapy and consideration for non-operative management. But taking this patient, is this someone where they would be considered for either of these strategies with this clinical response as well as this initial staging? And I'll start maybe with Dr. Patel to comment on the radiation approach.
Yeah, a very interesting time in rectal cancer with a lot of options for how to approach these cases. We have at our institution moved to offering a total neoadjuvant therapy approach to most patients now with locally advanced rectal cancer. So this is a paradigm where we give both the systemic chemotherapy as well as the radiation prior to surgery in some cases, and in some cases close surveillance without immediate surgery. In this particular case, I think an interesting choice to do the chemotherapy first and then short course radiation. In the TNT approach, when systemic therapy is given first, most of the published literature is then followed with chemoradiation. So when chemotherapy is given first, it's often chemoradiation as the follow-on treatment. There's excellent data to give short course radiation as the first treatment, followed by the systemic therapy. So in particular, the Rapido randomized trial used that paradigm where the short course radiation was first. And so what I think we've seen in several now trials is that if the radiation is given first, and then there's a longer interval from the end of radiation to an evaluation for surgery, you're more likely to have a better response, and in some cases, a complete response. And so, that might be, in this case, a reason to have considered maybe giving the short course prior to the systemic therapy.
Yeah, no, I think all good points. I'll move on to Dr. Weiser. I know your institution has been a leader in establishing non-operative management in some patients. So can you maybe give us a little bit of an overview of that and any comments about this specific case?
Yeah, I mean, I think the comments on radiation are quite good. What we've learned in non-operative management is that you do indeed need a longer interval of time between the end of radiation and reassessment. And as I brought up before for even esophageal, the thought that you have to operate at 6 weeks before fibrosis sets into the pelvis has been proven wrong. And we can wait 3-4 months. So it's become our standard to wait 3 months after radiation ends before making a final assessment if you need surgery or not. And this time is very critical to allow a complete response to evolve. That said, sorry.
Oh, go ahead.
Yeah. That said, we do fight now back and forth on should we give radiation first or chemo first. The OPRA trial, which was headed up by Dr. Garcia Aguilar, presented at ASCO but not yet published, indicated a higher rate of non-operative management or complete clinical response if you gave the radiation first. That said, those are hard comparisons to make, and we do need to wait for the final manuscript to really assess that finding. But I think in this case, I wonder if the short course was given due to COVID, trying to reduce the amount of time in hospital, because it would, in most centers, be standard to give chemoradiation if you're hoping to avoid surgery.
Yeah, that's a good point, and good pickup on the actual dates and timing of this case. I'll just let Dr. Benson comment briefly on chemotherapy and whether or not there are patients where you actually consider triplet drugs in the neoadjuvant space, like FOLFOXIRI.
Yes, I think there's interest in this. In fact, discussion about conducting randomized clinical trials looking at the FOLFOXIRI type approach of triple chemotherapy, particularly for the higher risk individuals. There also could be interest, for example, in these individuals where their tumors are more proximal. So we await the cooperative group prospect trial results, which compared a standard long course chemoradiation versus giving FOLFOX first. And then if patients had a good response, they avoided radiation and went on to surgery. And these were all the patients with the more proximal tumors, not the distal lesions. So it may be for these individuals with more proximal tumors that a triple drug combination may be most optimal. But all of this is being discussed. All the points made are certainly very important and under discussion. And I do think, certainly as people think about clinical trial designs incorporating radiation, there's a trend favoring giving radiation first, followed by chemotherapy, and then carefully assessing patients for a wait and watch approach. And all of that's being reviewed across the globe in terms of treatment strategies.
Yeah, exciting time for our patients for sure. It's a little bit of a difficult question being asked in this case is, what would be the recommendations for treatment if recurrence? Obviously, there's a lot of variables that go in here, but maybe I'll present briefly to Dr. Weiser the situation of a pelvic wall recurrence, let's say 6 months or a year later after surgery, and who do you consider for salvage operations in rectal cancer?
So we would want to go back to the original surgery, the original treatment before surgery, look at the pathology to see if there was a positive margin, maybe a surgical fail that we could improve upon. If the margins are negative and there was a long disease-free interval, we would be inclined to go in and try to resect those. Each case depends on the extent of disease in the pelvic sidewall, but we do think there's a role for surgery in these cases for sure.
Now I'll ask Dr. Patel a similar question. So one, maybe comment briefly on sort of intraoperative radiotherapy for some of these cases, whether or not there's a role, and two, thinking about, let's say, a local regional recurrence.
Yeah, in our approach, also, I think radiation sort of is viewed as, and in this case, maybe reirradiation would especially be used really to augment surgery. So if there was a concern that margins, for example, a pelvic sidewall, if there's extension to the sidewall, and there's a concern there, but potentially resectable, these are the types of cases where we might consider reirradiation. We often do, again, use proton beam in this type of a setting. And then that's where intraoperative radiation may also play a role, where at the time of resection, again, particularly in a challenging area for margins like a sidewall, that might be a great time to have the radiation oncologists on call to be ready to deliver an intraoperative dose if there's a question of the margin at the time of re-resection. So either re-irradiation in really pre-op in that case would be to me sort of the ideal use, or intraoperative radiation if available at the institution would be both ways to maybe address a margin issue. There are a few rare cases with sort of an isolated presacral failure or a lateralized lymph node failure where we really can get away with a pretty high dose of radiation. These are often difficult resections. So if resection is not technically feasible, there are a few circumstances where we can achieve, sort of curative intent doses with even if re-irradiation. But these are few and far between where the lesions are away from the rectum and away from the other luminal GI organs.
Yeah, no, I think very similar at our place as well. Dr. Benson, I'll give you a little bit of a different recurrence scenario. Let's say there's a relatively isolated hepatic recurrence with, let's say, 2 Mets in the same lobe. Are you approaching these patients curatively, and what is the general approach in that situation?
Yes, I think one important factor is the interval between completion of primary therapy and the recurrence. So if there's a recurrence in just a few months, we would certainly think about a curative approach with resection or ablation, depending on the location in the liver, but would give systemic therapy first to look at a test of time to make sure this wasn't a patient who would develop rapid recurrence either in the liver or in other organs such as the lungs. If the interval is quite long, 2 years, 3 years, in those situations, you can even consider going to surgery resection, although I think still many people would at least consider initial chemotherapy as a neoadjuvant approach, and then review and consider the patient for resection.
And just to get a little bit granular on your answer, is there what do you think of as sort of a minimum systemic duration before your general multi-D team would go towards an operation and someone getting systemic therapy before surgery?
Well, I think if you look at the period of time when we get the most shrinkage from systemic therapy, it's usually within the first few months. And after that, we may have stabilization, but not to the degree of shrinkage. If you're starting with someone who is already resectable, there's a concern that, well, maybe the lesions will disappear and resection will become a bit more difficult. So in general, I think considering about 3 months of neoadjuvant therapy and then surgery is a good strategy. You'll get to see if the patient has chemosensitivity, that there's some level of shrinkage. It's not as likely they'll totally disappear. And also, you're avoiding more potential liver toxicity from the chemotherapy.
Yeah, I agree. Our institution is generally on a 3-month sort of test initially, preoperatively as well. I'll say I think potential oligometastatic recurrence is an interesting topic, and maybe another place in the future where we can do some molecular risk stratification with circulating tumor DNA and et cetera.